developing during the human life, especially with the length in the spinal channel. The spinal channel, you know from the lectures from winter semester, that it's extending from a skull base till the sacral bone and coccygeal bone, and then inside is a tubular structure. But the spinal cord, medulla spinalis, is not localized in the whole spinal channel. The spinal cord typically ends in the upper lumbar region. In the newborn, it is the end of this spinal cord is at level L3. It's caused because the osseous channel is growing more fast than the spinal cord. It's very important then that in the adult we can find the lower tip of the spinal cord at a level about L1 or L1-2. Then the distant part of the spinal channel is filled by the dural sac, which is containing not spinal cord but containing spinal nerves roots. It's important from many clinical applications. We will note some of them. So please remember that in newborn the end could be at the level at 4L3. But it is typically in all textbooks, but in reality also in a newborn the spinal cord will be more above about L2. So this is the extent of the spinal cord. Please remember this. Then the spinal cord is localized in vertebral channel. Vertebral channel is made from osseous, ligamentous and cartilaginous structures. We talk sometimes about osseous channel even if the part of it is made from cartilages of intervertebral plates or ligaments which are covering vertebral bodies or joining arches. So typically we have to know that anterior borderline of a channel is made by vertebral body and dorsal is made by vertebral arch. But partially it's made from cartilages, like here, intervertebral disc, and dorsally we have ligaments which are called ligamenta flava, mainly dorsal ligamenta flava. So yellow discs, yellow ligaments. Then the spinal channel is containing soft tissues. From center to periphery, we have inside the spinal cord at levels where the spinal cord is, then is containing some neural structures arising or going into the spinal cord, so roots, and the whole spinal cord is localized in the sac of meninges, and from middle to periphery we can distinguish some meninges which are called soft or leptomeninges. Those are two, pia mater and arachnoidea, so it is a lepto meningeal coverage, and one is dura, which is called also pachymeninx. This is important because when you will have, probably very early, microbiology, then also physiology and neurology and pathology, then you will talk about leptomeningeal involvement, leptomeningitis. So typically infections which are affecting soft meninges, arachnoidea and pia. Typically it could be pneumococcal meningitis. It could be also some viral infections. And then we have a pachymeningitis, which is affecting the dura mater. And here we talking about the infection which is typically spreading to the central nervous system from outside, here from spine. Outside the meningeal sac and inside the osso-spinal channel is not empty space. The space is filled by loose connective tissue, fatty tissue, and venous plexuses. This is very important because when we compare it with the brain, we will have also this lecture about the meningeal coverage of the brain. We had one lecture during head lectures last semester. So when you remember that brain is covered by meninges and the dura mater has two layers, one is periosteal and the second is a real meningeal layer. Here we have only one layer which is meningeal, and what is outside is this epidural space. And this epidural space is very ideal environment for spreading of infection because there are many vessels, there are the ideal substrate, fatty tissue and loose connective tissue. So here is a space where could be very fast spread of infection, but also this is some space where, and I will show you, when we have a bulging of the disc or herniation of this, there is a space which could be occupied by this material without compression of the neural structures up to very large masses which could be here. So the next important is that from a spinal channel, and here this image is also from the first semester, we have foramina intervertebralia, intervertebral foramina. Those structures are the communication between central nervous system and with the peripheral tissues. Peripheral nervous system is emerging here. So spinal nerve is emerging from this foramen intervertebrale, and foramen intervertebrale is delineated by the osso structures. Osso structure upper is a vertebral body and pedicle of arch, and then upper facet or upper facet of the joint. So this is a lower articular process, and here is upper articular process. You can see here here is a intervertebral joint, and the last part, lower part, is again the pedicle, and the lower part of the anterior aspect of this foramen is made from disc. So then you can imagine that here are some structures which could be I think very frequently in my age, almost in all patients, all people, there are some degenerative diseases which are typical with production of osteophytes here, or bulging the disc. So then the spinal nerve here could be compressed in a stenosed foramen. So when we look at here at the magnetic resonance, you can see here the spinal nerve, disc, body, arches, and intervertebral joint. So magnetic resonance is the ideal imaging modality which is able to show those structures and also to show if it is not compressed, the emerging spinal nerve. Very important is that the spinal channel is not of the same size in all levels. And also, you probably know that the shape of foramen spinale, so spinal foramen in a vertebra, has different shape in different levels. This is a foramen magnum. Here is an oval or almost rounded. Then in a cervical spine, it is a triangular. Also in lumbar, it is a triangular. We can observe that we have some parts where are a little bit larger spaces in a spinal channel, in a dural sac, because there are very dense and very large and thick neural structures emerging from the spinal cord. So in dural sac, in subdural space, we can observe also some other differences during the whole extent of spinal channel. In foramen magnum, there is only a segment where is only spinal cord or interface between a spinal cord and oblongate. And in a cervical, we can observe that along spinal cord, we can observe here those structures which are roots. Why we have here those roots? Because I have said that the spinal cord is not grooving too fast like spinal channel, so then the retardation of the growth of the spinal cord cause that we have along the spinal cord roots which are going this way down. Longer we are, more structures we have here, and at the stop of the spinal cord, at a level of L2, we have here no structure which is corresponding to spinal cord, but there is some remnant in the middle, which is called filum terminale. So then, in the spinal channel between L2 and S2, sacral second segment, we have sac, which is containing only roots and filum terminale. So, this is a spinal channel. Now, spinal cord. I have said that the extent in the adult is from foramen magnum to L1-2. It is due to different velocity of growth, and I have said L3 in a newborn. The spinal cord, like the dural sac, has also different transition area. We have two sections of the spinal cord where we have swelling of the spinal cord, and those swellings are called intumescentia. Intumescent part is in cervical and lumbar. It's not only in a human, it's also in all quadrupeds, because there are nerves or nervous structures supplying muscles of the extremities. So then it's so large because they have not only those fibers, but also there are many neurons which are helping to coordinate emotions. So then we are talking about intumescentia cervicalis, cervical intumescentia, which contains spinal segments S5 to TH1, and it is corresponding, if you remember, to the segments of a brachial plexus in human. But what is important, again, back to the different growth of a spinal cord and spinal channel, this segment of a spinal cord corresponding to upper extremities is not at the level of those vertebrae, but at the level of C2 to C7. So it's a little bit shifted upwards. And here you can see also very important C5. I've told you that we have a very important nerve which is called nervus phrenicus, phrenic nerve, which is a supplying diaphragm. And diaphragm is our most important breathing muscle, and it has innervation by this phrenic nerve, and phrenic nerve has the segments typically which are L3 to C3 to C5, sometimes with C2. So then the most important root is a C4. So then, if I have said a C5, it is at the level C2. So the fractures and injuries in head-neck interface in level first and second cervical vertebra could lead to injury of the spinal cord in the segment which is responsible to innervation of diaphragm. So very fragmental injuries in this area, C1, C2, could lead to impairment of the breathing due to paresis or plagia of a phrenic nerve. So then this patient who has injury here has quadriplegia, so no motion of all four extremities, but also the patient is not able breathing without any support of artificial ventilation. So this is very important. So this is a very important clinical thing. The second intumescent area is in lumbar region, because there is a lumbar and sacral plexus which is innervating lower extremities, and those segments L1 to S3 are localized at the level of the last thoracic vertebra and first lumbar, so in the distant part. So we have two intumescentias, and then also the last part of the spinal cord has a conic shape and is called conus medullaris. Medullar cone, so easy to understand, easy to remember. From the tip, from the apex, we have interesting and important structure which is called filum terminale. This is a string which is fixing the spinal cord in the midline of a dural sac, and this thin structure is fixated to the tailbone, supporting this position of the medulla spinalis in the middle of the dural sac. What is filum terminale? It's the end of the cord which is arising from the conus medullaris and then is in the middle of dural sac. Dural sac then is ending at a level of S2, and then the dural coverages covering the filum terminale, and then the filum terminale is not surrounded by the fluid, cerebrospinal fluid, and it's ending and is fixing or is fixed to the tailbone, to coccygeal bone. So then, filum terminale has two parts. One is called PL. It's in the dural sac, surrounded by subarachnoidal space, surrounded by cerebrospinal fluid. And then the second is dural, and dural is covered by dura mater, but also layers derived from pia and arachnoidea, and is fixed to S2 segment of a tailbone. So this is a filum terminale. There are some pathologies which could be seen here. We can see in this region some malformations. Typically they could be found in newborns, mainly newborns, because we can see here also spina bifida, so not completely covered the defect dorsally from neural tube rolling. But also we can see in filum terminale some derivates, and inside the dural sac, derivates of a dermal coverage, which is called dermal sinus or sinus, which is a remnant of the rolling of the tube. So it could be here dermoid cyst, it could be here fatty tissue remnants, and other things, which could be sometimes very silent, discovered during some neurological problems in the adulthood. But mainly those malformations of, this is called also tethered cord syndrome. So this is a fixed medulla syndromes. So meninges. Meninges are membranes which are covering the central nervous system. The central nervous system has 3 layers of those. When we go from outside to inside, the first, like neurosurgeons see it when he or she is performing surgery of a spine, then it's a dural matter. So dural sac is surrounded by epidural space. We know there is a fatty tissue, veins, and the dura mater is following of a dura mater of intracranial space, but then is followed by only one layer, which is meningeal layer. And then the dura mater is going down till the end of the dural sac, we know, in S2 level, and then is covering filum terminale up to coccygeal insertion. What's happening laterally? Because from spinal cord are emerging roots forming spinal nerve, and then the dural coverage makes some sleeves of those nervous structures which are fused at the level of a spinal nerve with so-called epineurium, or it is following to epineurium. So the outside layer of the peripheral nervous system. So this is a continuation of this tissue. So then next layer of the meninges is arachnoidea. Arachnoidea is a thin web-like, spider web-like tissue which is surrounding subarachnoidal space. Inside arachnoidea is a fluid called cerebrospinal fluid, where it is originating. The cerebrospinal fluid is a product of a choroidal plexus in ventricular system of the brain, so in lateral ventricle, third and fourth ventricle, then is escaping at the level of medulla oblongata, the intracerebral space, and then is surrounding the central nervous system in subarachnoidal space, also spinal cord. It's not fused, it's not tightly connected to the dura mater, and then it's follow dural sac up to the end of the dural sac to S2. We have some connections which are fixing the spinal cord to the arachnoidea with bridges. Those bridges are seen typically dorsally in a midline. Here is a posterior, here is anterior, midline, and at the level of a posterior horn. We will have what is posterior horn on next slides. The third, the most inner or innermost layer of meninges is called pia mater. Pia mater is very well vascularized. It's containing small vessels supplying the own spinal cord, very similarly to the brain. It's adherent to the spinal cord surface, and it's important also that it is going into the fissure which is in the anterior aspect of a spinal cord, and this is called fissura mediana anterior. Also, this membrane is making sleeves, and those sleeves are covering those neural structures which are emerging from the spinal cord, so roots, but also smaller rootlets. First are rootlets, then are roots, and those sleeves follow also to the radices and then to the spinal nerves. Typically, we can see those triangular windows which are along here. You have here, what is here? This is radix, dorsal and ventral or posterior or anterior, and between it is window. Then it is this sleeve followed to a level where are fused anterior and posterior root. So this is important that there is blends with arachnoidea. We have then also one important structure derived from pia mater, which is very important for fixation of a spinal cord in the middle. If you can imagine, when we are walking, the horse is running, so the spinal cord could be fixated because due to those rapid motions, if it will be lying freely in the fluid, it will be movable and it could occur some injury of it. So this fixation is not only by this fixation points, but also very interesting structure which is some like wing or alar, or it could be like ear, and this is a ligament which is localized completely in a frontal plane, and it's fixing lateral parts of spinal cord to the dural sac, and it's called denticulate ligament, ligamentum denticulatum. So those are triangular anchors which are fixing the spinal cord in between two spinal nerves. So it's a very important. So how looks like meningeal sac? Those images from TMA Atlas nicely showing the difference between a C and L part. In a C part, we have here content of all structures. So here is a spinal cord, here those arachnoidal fixation parts, this is a denticulate ligament, here we have a rootlets, roots fusing, here on dorsal root is a spinal ganglion, and here is a sleeve of dura, which is then follow to epineurium of a spinal nerve. You can see that in a cervical channel there is a quite thin epidural space. So then, in a spinal channel at the level of a C, there is a more danger, compression and stenosis of all segments, because there is a relatively small space to be occupied by those pathological findings. Even if it is a fragment during fracture, even if it is tumor, even if it is a herniation of a disc. The different situation is the lumbar spine. Lumbar spine contains dural sac, which contain only roots. And roots are surrounded by the fluid, and the fluid could be compressed and could be smaller, the dural sac, and also it's a quite large epidural space which is surrounding dural sac. Then when we have some herniation of a disc, so the herniation of a disc could compress this epidural space earlier than is compressing the dural sac. So also large herniation of a disc or degenerative disease with stenosis due to osteophytes and hypertrophy of ligaments could lead to the neurological symptoms only when it is very, very advanced. So remember that meningeal sac contains in lumbar spine only roots, not spinal cord. So for clinical, it's very important localization of a lesion in the spinal channel. We can distinguish intramedular and intradural, extramedular, and then extradural. So 3 localizations. Here is an intramedular lesion. This is a developmental cyst. Cyst is localized inside the spinal cord, and typically spinal cord is like be inflated, but it's localized inside the dural sac and is surrounded by less and more by the fluid. So it is intramedular. Typically, those are lesions arising from CNS, really from spinal cord. Intradural and extramedular are localized inside the dural sac, but typically arising from meninges. So then it is compressing spinal cord from outside, but again partially surrounded by the fluid, because it's arising from dura mater or leptomeningeal, so typically meningioma or neurinoma in some clinical syndromes. In developmental also diseases like Recklinghausen disease, for example. And the last is extradural. Extradural is here. You can probably see on this magnetic resonance that the signal of those 2 vertebrae are slightly different. So this is some infiltration. The infiltration was by lymphoma. And here this is a tumorous tissue, which is, but here is seen that is a dural sac, and dural sac is inside. So this is, the lesion is outside dural sac. So then here is a compressed spinal cord and radices and dural sac. But important is when the neurosurgeon is going this way and performing surgery, it's not needed to be opened the intradural space and sac of meninges. So it's a much more convenient for surgery, but also with less complications. So those are localizations which are important. Intradural, extramedular, extradural, and inside the spinal cord intramedular. So spinal cord extend, we know that spinal cord is extending till L1, L2. Inner structures. CNS has 2 different substances or matters, gray and white. Gray matter is in a spinal cord, localized centrally. It has butterfly or H-shaped shape and is containing mainly neuronal bodies, so somata of neurons, but also it containing processes, glia, etc., etc. But the most important part, according to the appearance, macroscopic appearance of bodies, it's forming processes which are called columnae or cornua. Columna is in a 3D, and cornu, it is in the 2D. So cornu, this is cornu, 1, 2, 3, and here we have columna. Because spinal cord is organized in 3D, it's organized into the segments, and those segments are equipped with one pair of spinal nerves. Then we can observe that the functional unit of it is not only in a one plane in 2D, it is in 3D because it's organized more complex in also craniocaudal. So those parts, we will repeat it not only once, has 3 parts. It has anterior, lateral, and posterior. White matter. White matter is mainly made from axons and dendrites, but also contains glial substance. It needs to be here because we know that myelinization of a central nervous system is made by oligodendrocytes, so oligodendrocytes are there. The white matter is surrounding gray matter, and the thinnest, and this is very important, is between surface of a spinal cord and dorsal horns. It is forming, again, 3D structures which are called fasciculi or funiculi bundles. Those bundles could be organized in craniocaudal direction mainly, but also some of them are in the plane or in the segment in a horizontal orientation because it needs to be organized also neurons at the same level, so communications between neurons in the same spinal segment is made due to connections via this fasciculi. Some of those fasciculi forming so-called tracts, also pathways. So connections with centers which are centrally in a brain. It could be in a cerebellum, brainstem, also telencephalon. So, spinal cord. In Latin, medulla spinalis, in Czech, mícha hřbetní. So, this is a general shape which is not idle, as a schema which is showing the outside structures. The outside shape, we start at the anterior aspect. Anteriorly is a deep groove called fissura mediana, ventralis or ventral or anterior median fissure. It is very deep and is covered by pia mater. Then the surface is covered by pia mater, and then we can observe other grooves. This is schema which will correspond about C level of the spinal cord. Dorsally, in the midline, we have a sulcus dorsalis medianus, so dorsal groove, median dorsal groove. And 2 smaller, which are sulcus intermedius and dorsolateralis. They are shallow grooves which are dividing the bands of white matter in posterior funiculi, which are tractus, gracilis, and cuneatus. And we will have. So this shape is not idle. Probably it could be like this because the gray matter could be more to the surface. And here is a very thin layer of a white matter. So now I have to note one very, 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 very important thing. When you would like to be oriented on the schema, on anatomy, and then when you look at the images from radiology or books about imaging, neurosurgery, neurology, everywhere, very carefully you have to look what is anteriorly and what is dorsally. One sign is that the deep anterior groove is a fissura mediana, and the horn, which is near to the surface, is a dorsal horn. Why? Because in almost all anatomical books and schemas, the anterior is at the bottom. But when you have radiological images, the convention of imaging for more than 30 years is that you are looking at the patient like he or she is standing in the front of you, so on the right hand you have a left part of the patient. And the same is direction like to see from feet to head. So then dorsally is posterior and posterior is at the bottom. And anterior, you can see nicely here, C vertebra. And then here you can see the butterfly structure. And also, typically, dorsal horns are thinner than the anterior. And this is an example of the herniation of a disc in a sea level. And you can see that we very nicely could see this butterfly on a magnetic resonance. It's very important because when we have to assess if the spinal cord is injured or damaged or there is some, for example, demyelinization or ischemia, only one method how to look into the spinal cord is magnetic resonance. So, why is the space between dorsal roots and dorsal horns the distance is very short? Because here you have a pseudo-unipolar neuron, which dendrite is typically entering this way the spinal cord, and this is so-called Lissauer tract. And Lissauer tract is something which is enabling the communication of the outside neurons with the proper centers. And in several minutes we will hear about the projection of some sensations into the multiple segments. So this is the way how the fibers from one segment could go upwards or downwards to be irradiated information. So, important repetition. Dorsal root is information going into the spinal cord. Ventral root is going outside. Dorsally sensoric, ventrally motor fibers. The last structure, which was not described by me, is a central channel. Central channel should be filled by cerebrospinal fluid, but in almost all patients is not continuous, is not developing like one tube through the whole spinal cord. It could be disrupted somewhere because it is close secondary. So it's not like in a cerebrum, in brain, the inner liquor space should be continuous. Here could occur also some dilatation of those spaces, but it's not too much frequent. So this is the image of a cervical spinal cord, but this is a staining with the silver. Silver staining, classical staining used since 19th century for spinal cord and brain, showing here fibers and here somata. When we have more fibers, more gray is. So, substantia alba, once again, mainly contains neural fibers, glycia, neuronal bodies, and glia. And what has to be distinguished? We have many important names, sometimes similar, but what's to be distinguished is a columna cornu. Columna cornu is a gray matter. So this is this structure. Columna, columna, columna. Columna in 3D, cornu in 2D. Then fasciculi or funiculi. Do you know what is the difference between fascicle and funicular in English or in Latin? Fascicle is only when you have the branches of the one tree, which is bound by some ligature. And funicular, you know, you are skiing probably, and you know what is a funicular. Funicular is something, I don't know how it is in English, it's, for example, for sailing, the fibers are completely changing position and they are together forming something different. So better name is fascicle. So those funiculi, fasciculi, are localized in some peripheral parts. Then we have two radix and ramus. Radix is going into or going out the spinal cord, and ramus is a name of the branch of the spinal nerve or peripheral nerve. So it's not related to the central nervous system. So, and then it's important that we can distinguish the territories in a spinal cord where are localized. You know that here is information going into, so here are sensoric neurons, and here visceromotor, and here somatomotor, so motor. So anterior horns and lateral horns are motor, and dorsal are sensoric neurons. So those are those columnae in 3D and horns. So horn, columna. And it is a sensoric, autonomous, and motor. Those territories are the same and at all levels of a spinal cord. The same distribution of the quality of fibers is only in a posterior funiculi or fasciculi, because here are sensoric, only sensoric. But here in lateral funiculi and anterior funiculi could be mixed sensoric and motor. Sensoric and motor. We will see it early. White matter. And communication. At the same level. So, those are bands of white matter typically surrounding this butterfly, which is containing fibers of communication between neurons at the same level of the spinal cord. But also, we have some of them which are localized more vertically, and those are vertical structures which are communicating about several segments. Those are communications only in a spinal cord. We sometimes talking about inner circles, because this is only spinal communications. You will hear or you will see the patient in the future when the patient has some impairment of communication between brain and spinal cord, then some functions of a spinal cord are independent, so they are then without any supervision of a brain, then those are responsible for some important functions of a spinal cord which could be demasked with the injury of the upper region. So, the ratio between white and gray matter is different between the segments. So, the largest spinal cord at the surface and the largest number of fibers in a funiculi is logically in a cervical spine, because you could easily imagine that the fibers which are leading information from brain to the lower part of spinal cord and backwards has to be connected through the cervical spine. So then it's the logic that it is the largest volume of a white matter there. A relatively large is also in a lumbar region, because there are communications between left and right and segments upwards, downwards, because of coordination of the motion of the lower extremities, even coordination with the upper extremities. So then we have some gray matter structures. We have a zonal anatomy, which is an architecture, but it is not important to know. I have to say that for general knowledge of anatomy it's not needed, but typically you can remember they are 10. Those layers will be more important in a brain where we have 7 layers. Here is 10 layers, 10 architectural differences. But what is important is on the right side of the image, because there we have some important nuclei. Here, this is a schema. They are not ideally rounded. They are banana-shaped or bean-shaped or oval. Almost no is rounded. And you have to imagine that they are organized or assembled in columns, and the columna of the gray matter are inside nuclear columns, which are of the same function. So, this Lissauer tracts, I have said, it is a way of the communication with outside and also crossing with other segments. But then we have here, and please remember this, substantia gelatinosa, gelatinous substance, is important for pain. Then we have nucleus proprius, which is important gray matter, where is relayed information about crude touch. Clark's column, which is a more centrally. Clark's column is important for unconscious touch, or unconscious, not touch, proprioception. And then we have laterally intermedial lateral nucleus. I have said it is an autonomous column, so that is an autonomous motor center. And you could say me, in a spinal cord are those neurons mainly sympathetic or parasympathetic? Except sacral region, they are only sympathetic. Yeah? And then we have a group of a nuclei which are motor, somatomotor. We have a lateral group which contains gamma motor neurons, and medial which contains alpha. What's the difference between alpha and gamma? Gamma are innervating spindles in muscles, so muscular spindles, and alpha motor neurons directly stripped muscles affecting or which are making emotion. So they were nuclei. And here we have a funiculi. Important information about funiculi and nuclei is also that if you use Gray's anatomy for students, if you use Gray's Great Anatomy, the book with 2,000 or 5,000 pages, if you use textbook made from Time, for example, or Sobota, you can observe differences between those pictures because it's very hard to recognize where the bundles directly are and neurons, because the knowledges are derived from monkeys, rats, dead people, people who have some injury and lack of some function. So then you have to tolerate some differences. But what is important, that dorsally we have only tracts which are going upwards. In lateral, you can see here and here, they are some which are going upwards, some downwards. The same it's in anterior, downwards and upwards. So please, important is that dorsal funicles are only sensoric, the anterior funicles are mostly descending, and lateral are motor and sensoric. So we will now see some differences. I have said that the nuclei could have different shapes, but the organization of the gray matter is the same like in a cervical, same like in lumbar. In a cervical, we can observe here also some motor nuclei, which are then arising in a head, like head cranial nerves. So typically for 11th and 12th nerve, which are originally nerves of spinal cord, only arising a little bit upwards. So here you have those nuclei which are typically working with the information going from outside, sensor. And those are some effector neurons which have downwards information from upper structures, from brainstem, but also they take information from the same level, from sensoric, but not only from the same level on the same side, but from the other. But also they could assemble the information and they are modulated from upper and lower segments. So remember that anterior part is motor, dorsal is sensoric. And what about the Probably for you, very strange is brachial and lumbar plexus, because the nerves, for example, ulnar nerve takes neurons from several segments, but the whole somatotopic organization, the somatom, which is innervating something, then has this nuclear column. Nuclear column is, nicely here in orange, is a space which has neurons of the same function, but you can expect that we have millions of fibers. We have to have millions of neurons which are guiding the motion, but they have to be coordinated to do voluntary motion, non-uncoordinated contraction, which is not effective for motion. So then, because this nuclear column sometimes is more than one segment, typically 2-3 segments, then from the segment, the way outside is 3 spinal nerves, and then backwards it is fusing due to plexus crossing and forming final peripheral nerve, which is innervating one muscle. Yeah? This is the reason, because you can imagine again it, because the rootlets originally, if you have a very primitive vertebrate, or if you have an embryo, all rootlets are going outside. Then they are together, fixed to the spinal nerve, forming one segment, but peripherally muscles are fused different way, so then the original rootlets again are fused in a peripheral nerve for the summit organization of a muscle. So, it's very important that it is related to the functional connections. So, we could talk about some inner circles in a spinal cord. Because if you can imagine, when the cat is walking, the coordination of all 4 limbs has to be done, and you can observe that the coordination of a walking, very primitive, could be also without influence of the brain. So there were experiments in 19th, 20th century with the animals. From our point of view of ethics, incredibly horrible, but they are confirmed that the spinal cord is working itself, and every group of segments, sometimes one segment, is independent. But without coordination with the other, is not able to be effective to produce walking, to produce hunting, to produce eating, anything else. So which inner circles we have? The most primitive, the most easier to understand is that we have some sensation going into the segment with the dorsal root, and then the sensitive neuron is related to the sensitive neuron is localized in a spinal ganglion, and then motor neuron then is innervating muscle. So this primitive thing could be seen where? It could be seen, for example, in intercostal nerves, when it is a summit organization of a body. But it's not so easy, because for motor functions, there are also some informations from outside, some sensoric information which are tele. So it could be touch, it could be the wind is blowing, etc., etc. it's a heat or cold, and that this information has also some influence, and the influence could be transmitted to the same neuron with the affection, but also it could be transmitted to the other side, because if you are walking, the touch information from your foot from one side is transmitted to the other side. But also there is a way how to be this information projected into the supervisor centers and also to the levels of different level of a limb, so from upper to lower. So those inner circles could be then on one side only, yeah, but could be also transmitted upwards to the other side and also transmitted down. So it's very important to understand that neighborhood segments coordinate the activity, not only due to they have the nuclear columns for one nerve, but also they coordinate the function to the sensoric information made from outside, but also sensoric information from inside about the state of the musculoskeletal system. So then we can see some important things which are called also reflexes. Reflex is, very primitive reflex, which is typically a hammer to the tendon of a patella, and then this, or here, tendon is a hammer. Golgi tendon organ is transmitted the information, and then it's relayed and transmitted to the contraction of the muscle. But that is not only the one important thing. When you have to perform contraction and to make flexion of the knee or extension of the knee, you have to coordinate the motion with counterpart, with muscles which are, when you have contraction of flexors and extensors, both, it's not possible to move with the joint. So the coordination of those relaxations and contractions is made on the level, like seen here, because the axons, I have told you that the body has only one axon emerging from the body. But this axon could have some branches which could supply the information to the coordinating interneurons or to facilitate or inhibit some functions of other effector neurons. So, typical, very simple spinal reflex is seen here. It's not too much different from the previous image, but typically the sensoric information is then transmitted to the own motor neuron, then it is coordinated with something else in the other, and the motor neuron has an axon with a branch, and this is a feedback which is through the cell, intermediate cell, interneuron, which is then modificating, typically inhibiting. It's like to be not overheated muscle, not overheated, but the transmission on a plate between a neuron or axon and a fiber use acetylcholine. And the acetylcholine needs to be recovered, reuptake, produced, etc., etc. So this is something which is against the clonus, so clonic repeated overuse of a muscle. So simple reflexes, which will be used in neurology, when you will have neurology, are very simple. And I have said that almost no muscle is innervated by only one segment. So here is a C5, C6. Typically, this is a bicipital reflex, very simple. The second simple, which is reflex over here, triceps. Here, this is a typical patellar reflex affecting femoral nerve. Here, which nerve is innervating this muscle? This is gastrocnemius. Yes, tibialis or sciatic nerve, yeah, so tibial. Here it is a radial, and here is musculocutaneus. Yeah? So those are very simple reflexes. They are tested. They are tested with a neurologist or neurosurgeon to be sure that there is a completely fade out or it's over reflexing, because irritation or lack of function could be very important to distinguish the level of the injury of the spinal cord. So we are back in funiculi, fasciculi. So this is a nice schema. You will read the names, and then we will repeat the names during other schemas. This is a different. The previous one is from Gray's Anatomy, and this is from Wikipedia. It's not bad, but it's a little bit different. On Wikipedia is nicely seen here something else, that if you have here this, and this structure, and this structure, and you have here SLTC, and here CTLS. What's important? The organization of a spinal cord tracts is so-called somatotopic or somatotopy. What is it? This is a straight way from one segment to second segment, and the projection has some organization. This somatotopic organization you can observe in a spinal cord in those tracts. You can observe the same organization with some homunculus in a cerebellum, so also in thalamus, also in a cortex of a telencephalon, even if it is motor, even if it is sensoric. Because then it's clear that they have a straight connection which could be detected for the whole way from effector to the from central part to the effector. We talking also about the groups of those tracts. It's important when we have a dorsal or posterior, and the second is anterolateral system. When we will have, in the end, the vascular supply of a spinal cord, then it will be clear that we have some difference between innervation or relation between innervation and vascular supply and impairment of vascular supply. So remember that dorsally we have only bands which are going upwards. So ascendant tracts. Tracts of posterior funicle are gracilis and cuneatus. Gracilis is a medially, and it is related to lower extremity. And cuneatus is localized more lateral, and it is for upper extremity. So then, the gracilis is in a midline or along a midline, and easy to understand, because it's going from sacral and lumbar spine upwards, and then is from outside connected, not crossed, the line from upper extremities. Then we have two groups of tracts which are here and here. Those are spinocerebellar tracts, and they are spinothalamic. They are anterior and posterior and anterior and lateral. They are leading also the information of some sensoric sensations. And please remember that we have some differences. Those cuneatus and gracilis are not related at the level of spinal cord. Cerebellar and thalamic tracts are related to the next neuron at the level of a spinal cord. And then is also some difference will be noted that we have cerebral tracts with only 2 neurons, the other have 3 neurons. So gracilis and cuneatus. The cuneatus is then going from outside, be side by side with the gracilis. Gracilis is medially, cuneatus laterally. Both are related then at the level of an oblongate, where are 2 nuclei which are called the same way, gracilis and cuneatus. Then we have a next neuron in thalamus and projection into the cortical neuron, which is localized in a postcentral gyrus, which is dorsally from central sulcus. They have a very strong somatotopic organization. I have said the most medial is a sacral, so it's easy to understand. What is important? I have said that we have some coordination between limbs. The coordination between limbs has to be done with some connections. Those connections are so-called interpositioned descending tracts. Those are interfascicular, fasciculi, septomarginal, and dorsal triangle, which are typically, this is leading the information down, and this is the information, you know, probably everyone knows how is walking cat. The right and left anterior and dorsal are going upwards. Then it is changed going this way. It's a camel, then it's a different, or giraffe. They walking with the same side. This coordination is made by these connections, because informations about sensations from this limb is going to the segment of this limb. Even if I go in this, if you observe normal walking, you changing position of upper and lower extremities the same way like a cat or horse. So those are tracts which are communicating between those. So those tracts are the previous tracts, cuneatus gracilis, leading the tactile, fine touch, and the second information, which is very important, this is conscious proprioception. So information about motions of the muscles, tension of the tendons and ligaments. So this is a conscious sensoric information, sensations. Now we have tractus spinothalamici, spinothalamic tracts. What's important here? Important here is that we have two feelings, two sensations led by spinothalamic tracts. This spinothalamic tract has a first neuron, like all sensitive, in a spinal ganglion. And then it's important that we have a different ways of relay. This is this Lissauer tract, yeah, we know it. One is distributed, the signal, in several, up to 17 segments. And this is for a crude touch. What is crude touch? Fine touch is when I take a pen, I can write. I can feel that there is some button. This is a fine. The crude touch is a touch for tension. Typically, if you walk, the sensation about the body weight and also the surface of the floor. And then, more important, again in cats, that you have a feeling arising from the follicles of a hair. So then the fur and also the hair of a cat which is monitoring the space. So those are those crude touch. If you are outside and could feel the wind is blowing, even if it has a 37 degrees. So you can feel that the wind is blowing. So this is also crude touch. But what's important, this touch is not completely differentiable that it's from this point or this point. When the wind is blowing, you don't know if it is blowing on your dorsum of your hand or if it is on an arm. So because it is distributed to many segments. It is again to the safety or distribution of information about the surrounding environment. The second spinothalamic tract, and this distributed is this one. This is anterior spinothalamic tract. And then we have a lateral. Lateral is relayed here in posterior horn in substantia gelatinosa, and this gelatinous substance is relaying information about the pain, heat and cold. This is called nociception. And it's relayed, and then the axon of this second neuron is going up to the other side, is crossing the midline, and then going upwards to the brain, to the thalamus, in a lateral spinothalamic tract. So when is affected the anterior horn, anterior fascicle, or lateral fascicle, you have the problems with the crude touch and pain feelings. but not with the fine, because it is dorsal. So those tractus spinothalamici are leading this information, which is not too perfectly distinguishable. But second important thing is that they are crossed to the other side, and they are relayed at the level of a spinal cord, even in the same or different level, but the second neuron is ending at the level of thalamus, and the third neuron is then going to sensory cortex. Lateral spinothalamic tract has also three endings of neurons, or dendrites of pseudo-unipolar neurons. Spinocerebellar. Spinocerebellar are localized in lateral funicles. This is anterior and posterior one. They are both relayed at the level of the spinal cord, and the second neuron then has distribution, one on the one side and the second on both sides. But important is this is unconscious. Proprioception. So what is it? Dorsal has one neuron second in a Clark column, and then it is led into the cerebellum. And we have only two neurons. Also two neurons, but the axon is distributed to both tracts and going to the cerebellum, but from the upper peduncle, from the level of pons. What is this information? This is information again about the position of the muscles, tension of the muscles, but is led to the cerebellum to be coordinated with the information of a plan of a motion, which is made in the brain, and coordinated with the information about balance. This is balance information obtained from peripheral part, and then is connected with the information based on vestibular apparatus information from a skull. So then it is unconscious. You are not informed in your mind about it. So this is something which is automatic. There were sensoric feelings, sensoric tracts going upwards, ending in the brain, cerebellum, thalamus, and then the next neuron in a cortex. Descending tracts are motor. We have also two groups. One is called pyramidal, and the second is extra. Pyramidal tracts are so-called also corticospinal. Why they are called this? Because we have a great bad pyramids, so some like this, neurons, with one long axon. This long axon is somewhere ending here. We have two corticospinal tracts in a spinal cord. One is lateral and one is anterior. Then we have also one tract which is also quite important. This is a rubrospinal tract. Rubrospinal tract is in lateral funicles from red nucleus. What's important? those pyramidal corticospinal tracts, we have an important thing, which is that this lateral is about 80% of all corticospinal fibers, which are crossed in decussatio pyramidum at the level of a oblongate. We will see it next lecture. And 20% are not crossed at the level of a oblongate, but crossing at the level of the spinal cord. So what it means? It means that all corticospinal fibers are crossing and they are going to the other side. So neurons for motions of my left hand are in my right hemisphere. But 80% of all are crossed at the level of the brainstem and 20 at the level of the segment where are motor neurons localized. So those are these corticospinal tracts. I have said that we have a red nucleus. Red nucleus is a structure, motor structure, which is localized at the level of a mesencephalon. And red nucleus then is very important for coordination of not involuntary motions, but automatic motions, which are typically when you are cycling, when you are walking on the stairway, or if you are using in a car, you are changing the velocity if you don't have an automat. So those are, you don't think about those motions. Now, when I'm doing some lines here, only not. Those are automatic things which are relayed by this and guided by this red nucleus. Then we have also motor tracts which are anteriorly localized. They are extrapyramid, also extrapyramid, but they are from some archaic structures in the brainstem. Here are two of them, tectospinal, vestibulospinal, and reticulospinal. It should be also olivospinal. Again, when you look at different schemas, you can see what's important for those. Those are supporting fibers, for example, when you are awake or when you are sleeping. When you are sleeping, your muscles are in different tension than when you are awake. Because when you are awake, your muscles are ready to do some motion. So this is typically guided by reticular formation, and those fibers are going through the reticulospinal tract. Then we have a vestibulo and olivospinal. Vestibulo and olivospinal tract is a modification of a motion through the systems of a cerebellum and vestibular system. So what? For balance, typically, or postural functions. And the last one is a tectospinal, which is a very, very interesting. We will have that the tectum. Tectum is a part of mesencephalon, where are localized colliculi superiores and inferiores, centers which are relaying visual and auditory information. So those tectospinal are typically when you are walking, crossing the street, and the car is coming, and you hear and see in the peripheral part of your field the car, you change your position. Or typically, when you can see the gepard is hunting gazelle, and the gazelle is changing position, guepard is able to follow the direction. Those are the guidances made by this visual subcortical and auditory subcortical information. So this is a tactospinal tract. So those tracts are supporting coordination and adjusting the force and coordination of a neuron. So then we have one motor neuron. I have said it very easy to understand that one neuron has a sensitive and then executive function. But this neuron is under influence of many other informations, which are typically they are inhibiting the function. So inhibiting due to coordination of emotions, coordinating because you are awake or you are sleeping, you are hunting or you are hunted. Yeah? So this is everything, and you can see how those tracts then are influencing the motor neurons. About the motion sensations, I have told you about proprioception. Proprioception is very important, sensitive information which is going from inside of the human body. It's not pain, but everything what is about the tension of a muscle, what is about the tension of a tendon, then this is called proprioception. Conscious is typically led by funiculus posterior, by gracilis and cuneatus. They are feelings from Golgi tendon apparatus or from a spindles, because a spindle has a sensitive neuron and it has its own gamma motor neuron. It's important to know and to imagine how the muscle is able to be monitored in its tension and motion, because it is like a string. If you have a guitar and the string is not properly in a tension, then the sound is not proper. This is a brrr, not making a normal sound, normal A. So then the spindle has to be under contraction, could be in the tension, then the information about the changes of a tension then are created by the ending of the sensitive neuron. The inconscious is led by spinocerebral tract and is led typically to the cerebellum during cyclic motions. Yeah? It's about information about balance. When you are walking, the brain has information when you have position, and then you are in a proper position, because the cerebellum is able to coordinate motion at the level of control of or feedback and control how the motor system is executing the plan of a telencephal. Yeah? I have planned to learn anatomy to be ready in the end of the May. And you have a description of a plan, and the cerebellum is making the control like your father or mother if you have done what you have read, what you have wrote. So, the perception and leading of those things. We have a fine tactile perception. Fine tactile is typically where you have no hair, palms and plant foot. They are those feelings from this skin, which has a very thin layer of epidermis. And they are many fine specialized Vater Pacini, Meissner corpuscles, and other things. And they are led to the oblongate through the funiculi posterior. But a rough perception is typically made from tactile discs and also from hair connections, and they are led by spinothalamic lateral tracts. But they have distribution -15 to +2 segments, so 70 segments. And pain, heat, and cold, called nociception, they have atomized free endings, and the projection is in only one segment. So you are able to concrete describe where your pain is. Why it's important? Yeah, because a bee give you a sting, so you know if it is on a thumb or on a meninges. Yeah. But the importance of this rough touch was described. So here you have then assume, so pain, heat, cold, yeah, where what is associated. So now we turn to radicus, roots, and description of those structures which are known for you. Once again, but I hope that some are not able to say that dorsal information with dorsal root is going inside and sensoric and motor is going anteriorly. And then we have a spinal nerve, and the spinal nerve is something different than the root, and the spinal nerve is a peripheral nerve which is divided into the ventral and dorsal branches. So then it's important. So spinal nerves, we have 31 spinal nerves. Who are from Germany? Yeah, small, well, about a half. When you look at the T-map, you will see that there is probably 32, because some German old anatomy school is talking that coccygeal segment are true. Probably it's true. Why? Because this is a rudimental thing. Because again, for example, cat has a long tail, and there are many segments. For us, it is not important because it is too much small that it is innervating only 1-2 millimeters around the anal region. So it's not important, and it's in a segment which is less 1 millimeter. So typically, what is important that we have 7 cervical vertebrae, but 8 cervical nerves. Why? Because our foramen magnum is original some C0, which is fused with occipital bone. Then probably you can say yes, but next spinal nerve in reality is a hypoglossal nerve, which is emerging school, but if you will be at the level of the fish, then there is a real spinal nerve. Again, when you look at the trigeminus, really, in a shark it will be spinal nerve, because our cranial part of brain is a little bit different, because we have seen that the multiple segments are communicating and the information could escape from the spinal cord on the different level. So then we can have very similar functions for some cranial nerves which are related to the spinal nerves. So then it is easy, 12 thoracic and 5 lumbar and 5 sacral. We have heard about it, and on magnetic resonance you can see what is here. This is a dorsal sensoric root. Here is a tiny motor. Why is motor thinner than sensoric? Because it's only motor for muscles and motor for sweat glands, for example. But now we had proprioception, tactile information, pain, rough touch or crude touch. So then there are more fibers in a dorsal root. So that is a thicker, and now you can see it, it's easy. The spinal ganglion is somewhere here, it's fusing and then is escaping. Important is, I have said that spinal nerves emerging spinal channel at the level of an intervertebral foramen. And now we have to count them, because can you imagine that you are a neurosurgeon, you have to perform surgery and you have to see where it is. I, as a radiologist, I have to describe the fine, precise level where is the image. And he knows where is a functional image in the segment, and we have to coordinate it. And in the winter semester, I have said that also segmentation of vertebrae is not completely in 100% the same, that we have some lumbarization, sacralization, etc., etc. So then it's important to know that below skull base is a C1 emerging, and then in a C level we have a 8, and typically it is the same number of the spinal nerve above the same arch of the vertebra. So above C1 vertebra is a C1 up to TH1. Above TH1 is a C8. Yeah? Then this is a borderline where we all numbers of the spinal nerves have below this. So when you have a patient with a stenosis at the level L2, L3, so then the stenosis is affecting the spinal nerve or root. Sometimes it could be only one of the roots, sensitive or motor. So with L2, 3, it's L2 affected below. At the level of C5, C6, it's a C6. Yeah? Very important. So then we know also that in the sacral and lumbar region we have no spinal cord, only roots. The last nerve, which is called coccygeal nerve contains CO or CO12 in Germany. It's emerging below cornua of a tailbone. So here, once again, the transition of nomenclature of nerves. C7, and here is C8. TH1, and here is TH1. Yeah? It was intermezzo with the spinal nerves, but content of a dural sac below L1, 2 is not only fluid. There are localized radices which are together forming horse tail or cauda equina. We also, or you will hear about cauda equina syndrome, which is a compression of all those structures inside spinal channel. This is a magnetic resonance in L1 region and here about L3. What's the difference here? This is a rest, this is a cone of the spinal cord, yeah? And here you have a roots. Roots are assembled that the most medial are the lowest and most lateral are they which are emerging. And very frequently you can see the assemblance of the two. And again, the motor, which is anterior, is thinner than the sensoric, if you can see it on this image. And here, if we are at this level, or this level, when it is L1, this is L2, and here is L1. And here is TH12. And here we have L3. Yeah? The somatotopic organization is also in a cauda. Cauda then is following to the sacral roots, and the sacral roots are then going with the sleeves of dura mater in a free epidural space where is fatty tissue in a channel. And then it's emerging anteriorly or dorsally from the sacral bone through the sacral foramina, 4 sacral foramina. The last one is going below here. So then important is lumbar puncture. Lumbar puncture, what is it? Lumbar puncture is a procedure when you insert a needle into the lumbar channel and you could do something. You can take a sample for cerebrospinal fluid, which is very important in some diseases, typically inflammations, and then when a patient has symptoms of meningitis, they take a sample to assess something. Also take a sample now for some molecules which are typical for multiple sclerosis. Today also tau proteins, typical for Alzheimer's disease, etc., 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 because cerebrospinal fluid is a very, very important source of information from biochemical analysis. Then the second option is to perform here some anesthetics, because anesthesia could be done in a sacral region or in lumbar and sacral region in epidural space when, for example, for sectio caesarea or some pelvic surgeries could be very effective to perform also this local type of anesthesia without general anesthesia. For example, if you have a patient with some contraindications to general anesthesia and she or he needs, for example, a replacement of a hip joint, so then it could be used this one. The last option is sacral hiatus injection of this anesthetics. So last section, not too long, we will be finished, I think, in 15 minutes. So this is vascular supply. The spinal cord has a longitudinal system of 3 arteries, which are anterior spinal artery and 2 posterior spinal arteries. They are going along a whole extent of a spinal cord, and they are fed by the feeders which are on the several segmental levels. Not in all, completely developed. And the feeder system then is providing blood through the spinal segmental arteries. The spinal segmental arteries are the same organization, but could be fed not in all segments. Then the artery, which is seen here, intercostal artery, is then here, intercostal anterior branch. We know that it has dorsal branch, and from dorsal branch, the branch is following spinal nerve and divided into the anterior and the posterior branch, which is then following radiculi, and then some main are feeding the anterior artery. The anterior artery has a very important one supplier, which is called arteria radicularis magna, Adamkiewicz artery. Adamkiewicz artery is a thick artery, typically supplying the segment of lumbar intumescence. And this intumescence is fed by artery which has not stable level of the origin. It could be in the dorsal, thoracic, and proximal lumbar, from lumbar arteries or intercostal arteries. But in some kinds of organization of vessels, it could be also from branchial arteries. This artery is named after Adamkiewicz. It is a very clinical term, and it's important that occlusion of this artery leads to severe ischemia of a lumbar segment and then to paraplegia of the patient. So then it's prone for ischemia, this intumescentia, and it's important then we have some situations where it is in danger of ischemia. So it could be acute injury of a thoracic aorta. When we treat it, even we as radiologists cover the tear with a stent graft or surgeon replacement with some graft. Then the occlusion of it could occur ischemia as a complication of this life-threatening situation, procedure. Then the second is when you have, for example, dissection of the aorta. So this is the reason why we, during some interventions, finding the origin to be protected against this. Also, when we perform, for example, embolization of bleeding of a branchial artery, we have to be sure that the branchial artery is not associated with this Adamkiewicz artery. The Adamkiewicz artery is seen here on this angiogram, and we can see this like, this is Adamkiewicz artery, and this is the feeder. And you can see that the feeder is crossing several levels. So, and this is this level. So, about those arteries. I have said to you that the anterior fissure is very deep and is covered by pia. And pia is vascularized membrane. Pia is hosting branches of arteries which are supplying the central nervous system. And here is the system, how the arteries are then going into the butterfly and feeding almost all gray matter. And this is going through the anterior system, not through the posterior. The anterior system then is prone to make a larger damage of a tissue than the posterior one. And then you can imagine that more dangerous structures are from anterior, and the compression of anterior system could occur. And also the next thing is that this artery is larger, so then also the embolization is easier to larger than the smaller artery. So then this anterior territory is more prone to be ischemic. And the ischemia of anterior segment is a larger with the impact to the function of the spinal cord, because what is happening? In every situation, the motor neurons are damaged. Mainly also some for pain. Some for rough touch and the pain, which is about here. So then, sometimes the patient is able to feel pain, and very frequently is not tactile impaired. So then, we have almost this heart with anterior spinal artery supplied. Veins. Veins are easy to understand, because we know that veins are follow arteries. Here, anterior artery is followed by one largest vein. Then here we have artery, and here, and they are followed by two veins. And then we have a separate venous system, which are not associated with arteries, in midline dorsally and anteriorly around the roots. So then finally we have a 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 veins. 5 and 5. So then those veins are connected at the level of the foramen intervertebrale with an extra dural space where are localized ridge webs of veins called plexus vertebralis internus. It's in fatty tissue in extradural space. And once again, I have here comment about the spread of infection, because infection very frequently leads to damage of a fatty tissue. Then it could be affected the vascular system, occurring thrombosis, which is infected, and then also could be the infection then distributed through the bloodstream to somewhere else place. So those are veins. And those veins, and here is also important thing, that those veins which are outside the dural sac are communicating with this venous system of a bone marrow of a vertebra. And probably you remember that red bone marrow is through the whole life localized in vertebral bodies. So then those veins are with a quite high flow. And when you can imagine that the infection is hosting somewhere here, could in a intervertebral disc, then the infection could be transmitted to the extradural space. Here could be thrombosis, thrombophlebitis. Then what could happen? Swelling of the soft tissues. It could be compressed somewhere. The venous system of the spinal cord inside dural sac, and then this compression lead to hypoxia of the spinal cord. So then finally the plegia of the patient of paresis could be caused by the consequence of the vascular supply and mainly venous drainage, because vein is really easy to be compressed. Yeah, that's all.